Hi, good afternoon, and welcome everyone to today's session. Today is the much-awaited webinar on the great debate, aiming to answer the eternal question of MRI versus CT in the assessment of pulmonary veins and vascular rings. This is a joint session held by both SCCT and SCMR. The format of today's session will be a debate where each speaker will have 10 minutes to talk about their pro-MRI or pro-CT stance respectively, followed by an opportunity for a 5-minute rebuttal. I am Simone Javeri, a pediatric cardiologist at Columbia University in New York, and will be chairing this session along with my colleague, Dr. Saira Siddiqui from Morristown, New Jersey.
Good afternoon, everyone. Thank you, Simone, and thank you to SCCT and SCMR for co-hosting this webinar. Before we get started, I just wanted to cover a few housekeeping items. The webinar today will be 70 minutes long. We encourage you to ask questions throughout the presentation. To do so, you simply use the Q&A function in the chat box, and we'll try to address as many of those questions as we can at the end of both of the vascular ring and pulmonary vein sessions. Now I would like to turn it over to our fabulous speakers.
So we'll start off with our first debate on vascular rings. We have two speakers. Our first speaker will be Dr. Nao Sasaki, who is a pediatric cardiologist at Boston Children's Hospital and assistant professor of pediatrics at Harvard Medical School, who will be taking the pro-CT stance, followed by Dr. Simon Lee, who is associate professor of pediatrics at the Northwestern University Feinberg School of Medicine. Without further ado, I'll hand it over to them.
All right, thank you for the introduction, and thank you for the organizers for inviting me to participate in this debate, the great debate, CT versus MRI for vascular rings, and I'll be talking about CT today. Before we move on, no disclosures. Before we move on, I'd like to briefly review what vascular ring is. So it's when the trachea and esophagus are completely surrounded by vascular structures. The vascular structure does not need to be patent. That means ligamentum arteriosum or atretic segment of an aortic arch may form a complete ring. No imaging modality can visualize the atretic segments, so this leads to diagnostic challenge without adequate knowledge of vascular anomalies. Best time to diagnose vascular rings that involve ductus arteriosus is prenatally. So there are different types of vascular rings, as you know, and they can be divided into 4 main categories: the right aortic arch with an aberrant left subclavian artery and left ductus arteriosus or ligamentum arteriosum when it closes. This is the most common type of vascular ring. The second most common is the double aortic arch. Right aortic arch with mirror image branching and left posterior ductus arteriosus or ligamentum. This is considered a rare type of vascular ring. And then there's the left aortic arch with aberrant right subclavian artery and right posterior ductus arteriosus or ligamentum. This is considered a very rare type of vascular ring. So one of the first questions I was asked to address is when to use cardiac CT for vascular rings. We know that about 70% of patients are diagnosed prenatally by fetal echocardiograms nowadays. And then most patients, I think, will get full echo, transthoracic echo postnatally prior to discharge for confirmation of prenatal diagnosis. And then they get discharged home if they don't have any symptoms. And then we can say that most patients get CT when they become symptomatic, but I think that really depends on the practice. And then it gets a little bit more tricky when the patients are asymptomatic. I think the indication and timing for this group of patients really varies by practice. This is from a paper published in Annals of Thoracic Surgery by the group led by Dr. Elizabeth Stevens. So this is the management of patients diagnosed prenatally with vascular rings. So you can see here in the middle, if you're symptomatic, they recommend CT, not MRI, prior to surgery for surgical planning. Even for patients who are asymptomatic, they recommend CT, again, not MRI, around 2 to 4 months of age. And I think this indication is somewhat debatable. The second question is role of dynamic airway imaging with CT. I wanted to disclose that we don't really do this at Boston Children's Hospital. However, I do think that it's very helpful. It allows for visualization of dynamic changes to the trachea and at times the esophagus as well due to external vascular compression. Some patients have associated tracheal bronchomalacia with airway obstruction and compression in multiple sites in patients with vascular rings. Dynamic airway imaging can clarify the mechanism of airway obstruction. There's potential for this to replace bronchoscopy, and it actually provides superior spatial orientation compared to regular bronchoscopy. It doesn't require a patient to be anesthetized or require intubation, and it can visualize dynamic airway obstruction in physiologic state without being intubated and have positive pressure ventilation. Sorry. And then this is really just a quick review of how we do the dynamic airway scanning. You can do this as prospective in step and shoot mode, or you can do retrospective CT. The only negative of doing the dynamic airway imaging is that it does require higher radiation dose than a regular high-pitched turboflash that we typically do for vascular rings. This is an example of virtual bronchoscopy from the dynamic airway CT. You can see that there is airway compression related to the respiratory cycle in images like this. And then I'll end with showing some interesting cases using CT. This is a case of a typical right aortic arch, aberrant left subclavian. You can see the head and neck vessels there first, followed by the right aortic arch. There you see the aberrant left subclavian. This patient doesn't really have significant airway compression, and the arch continues to descend on the right side. This was in a 3-month-old baby with about 6 kilos, unsedated and crying. I gave 1.7 cc's per kilo of contrast. The total DAP was only 7. That equals to about 0.6 millisieverts of radiation. So very, very low radiation, and we get this beautiful image. This is a baby with tetralogy of Fallot, right aortic arch, and aberrant left subclavian. The area of aberrant subclavian is kind of obscured by the nasogastric tube, but you can clearly see the aberrant left subclavian. We did this in a 2-week-old baby because of poor weight gain from failure to feed well. There was a left posterior ductus seen on fetal echo, so it was confirmed to be a vascular ring prenatally. The baby only weighed 2.7 kilos. We gave 1.9 cc's of contrast. Total DLP in this case was only 4 with 0.3 millisieverts, so very low radiation again. Next case is a double aortic arch. You can see 2 good-sized arches. In this case, there was a significant narrowing of the trachea, and that was the indication to do CT. This was a 5-week-old patient who presented in significant respiratory distress and was admitted to a cardiac ICU. The baby almost weighed 4 kilos. The baby was unsedated and tachypnic, but despite that, we got this beautiful image on CT. Again, very low radiation, total DLP of 4 with a millisievert was 0.3. There was because of a very high resolution image, we were able to get very good measurements of the arch. The left arch had borderline low normal size, but the surgeon decided to ligate the right arch instead of the left, so to prevent this from becoming a circumflex arch. This is another case of double aortic arch with atretic left arch. When we reconstructed, you can see the one on the left is this patient where the atretic segment is quite long, whereas on the right example, the atretic segment is quite short. And then we get into more rare types of vascular rings. So this is right aortic arch with mirror image branching with left posterior ligamentum. You can see here in the 3D image. So this was actually confirmed by surgical inspection to be this type of vascular ring. And then the last case here I'll show is it's a left aortic arch with an aberrant right subclavian artery and right posterior ligamentum. This is a rare type of ring. This is what it looks like reconstructed to 3D. And again, this was confirmed by surgical inspection. So just to summarize, CT provides excellent anatomic delineation of all types of vascular rings, including the very rare types. CT is very fast and can be performed with very low radiation and without sedation. Dynamic CT airway can provide additional information on the mechanism of airway obstruction. Most patients with symptomatic vascular rings get CT prior to surgery. Some centers even recommend CT in the first several months, even if the patients are asymptomatic. And that's it. Thank you very much.
Okay. Thank you, Dr. Sasaki. Thanks to the organizers for inviting me to speak on this topic. I am pro MRI for vascular ring. And I have no disclosures. So some of you may not know, but Dr. Sasaki and I actually went to the same fellowship, although we didn't overlap. So you would think that I would have a lot of really great dirt on her, a lot of funny stories to make fun of her about, but nothing. She is clean, squeaky, squeaky clean. So we'll just have to rely on my poor debate skills to try to win this. So one thing I do want to disclose is that I am my interests are in Kawasaki disease and coronary anomalies. So I am a big fan of CT. I'm at Lurie Children's Hospital, which is a big institution that loves CT. Give me my beautiful coronary imaging, multiplanar reformats, 3D renders any day of the week. But the question is not, is CT a great modality? The question is CT the best modality for evaluating a vascular ring? And we've just heard all about how great CT is for vascular rings, how it provides great visualization, probably some nice pictures of the airway. But I'm going to argue that CMR can provide the same nice imaging of the vasculature without some of the downsides of CT. And while we just heard about how great the airway visualization of CT is, I want to ask, how much does visualizing the airway really affect clinical decision-making in a patient who is asymptomatic? And really, who should be referred for surgery? So I'm going to argue that only symptomatic patients should be referred for surgery, and we should not be operating on patients based on non-invasive imaging findings. And so one of the main advantages of CT, which would be visualizing the airway, I'm going to argue is probably less impactful than we think. So 3 arguments that I'm going to give to support this premise. First, CMR is tried and true method of anatomically verifying anatomy without the downsides of radiation and potentially without even contrast. Second, I don't think we have the data to suggest that we should be operating on patients based on airway narrowing we see on CT in the absence of symptoms. And third, I think we're actually, as Dr. Sasaki touched on, we're getting pretty good at picking these patients up prenatally. So that should really allow us to be more attuned to identifying symptoms. So first, I'll go through CMR and the anatomy delineation. Many of us know CMR is a one-stop shop. You can evaluate ventricular volumes, function, tissue characterization, in addition to angiography to evaluate extracardiac anatomy. And in a recent study by Gikandi et al., they found that almost 20% of the patients that they operated on with vascular rings had some genetic syndrome, and 9% of those patients presented with cardiac symptoms. And so some of these additional tools in the toolbox of CMR probably would have been helpful in some of these cases. And now more specifically from CMR versus CT, again, no nephrotoxic and apparently now potentially thyrotoxic contrast agents when using CMR. We've got a couple of different contrast options, gadolinium-based or ferromoxetol, which is iron-based. Potentially, if we want, no contrast at all. And I'm going to show a couple of examples of that. And then even if we talk about airway imaging, it's not like we don't see the airway at all by CMR. We can utilize black blood imaging to give us a gross evaluation of the airway as well. And then kind of the time-old thing that we keep, beating the dead horse on about CT is no ionizing radiation with CMR as compared to CT. So first, like I mentioned, there are multiple techniques to image the structures. First, there are kind of the typical gadolinium-based structures. And here are two examples. Both of these patients have a double aortic arch. This first patient on the left actually was an 18-year-old who was incidentally diagnosed with a double aortic arch when they went for a CMR when they were diagnosed with MISC. And so we actually found out that they had a double aortic arch. They said they were asymptomatic, never had problems, eventually convinced them to have surgery. And it turns out that, and this is not atypical of a story, it turns out that he was one of those kids who would cut all of their food into really, really small bites to eat it because he was having some swallowing difficulties. And then we kind of realized that after the fact. And so again, really nice imaging here. You can see. And then the second patient here is another patient with a double aortic arch with an atretic left segment. Both of these patients were scanned using gadolinium-based contrast. This first patient was a 3T scanner using a ECG-gated, respiratory-navigated IR flash, slow infusion of contrast. And the second patient underwent a conventional breath-held MRA on our 1.5T scanner. And you can see really beautiful images of their vascular ring. Next, if you don't want to use gadolinium-based contrast, ferumoxytol, great choice. A lot of reasons for that. One, again, it's an alternative to those who want to avoid gadolinium-based contrasts. It is an iron-based contrast and actually is clinically used for iron deficiency. It's also extremely helpful in a subset of patients with additional congenital heart disease. Now, this example is a 6-month-old patient, DeGeorge syndrome, TET-type double outlet right ventricle, unbalanced AVSD, who also just happened to have a right aortic arch with an aberrant left subclavian artery and a left ductus. And so this patient actually, we wanted to get information of looking at their LV volumes and some of their flow data to try to decide were they a candidate for biventricular repair. And so this is a really nice case of where we were able to use ferumoxytol to delineate the vascular ring anatomy, but also answer some of these other questions not related to the vascular ring. Next, we have some non-contrast options. This is a patient with a right aortic arch, aberrant left subclavian artery with a diverticulum commoral. And this patient underwent a non-contrast, ECG-gated, respiratory navigated 3D whole heart SSFP. So no contrast. We have good imaging of their vascular ring and the aortic arch with the diverticulum. And you can also see a little bit of their airway and esophagus on this image as well. And the next would really be the workhorse of, when we want to look at the airway or esophagus and things like that, this would be dark blood imaging. And so we have a couple of options for this as well. Here you can have static imaging. So this is a stack of 2D coronal images. This is a T2 weighted double IR dark blood imaging. We also have the option of getting a 3D data set that can be multiplanar reformatted. So this is an example of a T1 weighted 3D turbospin echo sequence, both of which were obtained on a 1.5T scanner. And so this would be, you can see that we get some nice visualization of the airway and esophagus as well. This would be in the form of a 3D data set, which can be reformatted as we would see fit. And then the last part about the contrast agents, many of you have probably heard about the FDA recommendation for thyroid monitoring, and I'm not here to say that that there is a true risk of thyroid dysfunction. But I do think it is a consideration because, at least in our institution, when we have patients that are less than 3 months old with a vascular ring and they do get a CT scan, we do recommend that we have them get thyroid function tests. So again, it's kind of a conversation with the family of, there is this recommendation. We're going to check the thyroid function. Your child needs to get another blood draw. They need to wait for the results. Do they need to get evaluated, repeat testing? I think it's a consideration when we talk about contrast, particularly in this age, which is really the ideal feed and swaddle age. And then I really loved those images that Dr. Sasaki showed. I was marveling at, the radiation dose, but again, not all centers are going to have the latest and greatest photon counting, dual energy, dual source, super fast CT scanners. there are going to be a lot of centers who are still using older generation CT scanners as well. And I think that's an important consideration, especially when we're talking about radiation dose. And I think we've done a really great job of utilizing the principle of ALARA, but at the same time, I do think it's something to consider. And just to give a little bit of perspective, I found two studies that were looking at the effective dose from older generation scanners. This was first study by Jadav et al. We're honestly comparing their newer generation to their older generation scanner. They had a large detector 320 multi-detector CT compared to their ungated helical 64 multi-detector CT scans in infants and neonates. And when they looked at their ungated older generation scans, they found that the effective dose in those infants and neonates was actually 4.8 plus or minus 1.4 millisieverts, and again, ungated. So certainly a bit higher than what we just heard from Dr. Sasaki. And this is another study, Herzog et al., also from AJR. Now, this was a study utilizing their older generation scanners, but trying to apply the principles of ALARA. And again, you can see they found in their study, or reported anyway, that in their pediatric age patients, they had an effective dose of 2.5 plus or minus 2.1. So again, just a consideration. So next, I'm going to talk about how the CT airway evaluation, does it really change the indication for surgical referral in asymptomatic patients? And what is really the role in these patients? So this was a nice abstract that was recently presented at SCCT scientific sessions. They tried to look, this single center group, which you may notice one of our great moderators is on here, Dr. Javeri. They tried to see if the area of the trachea, tracheal narrowing on CT scan for vascular ring patients correlated with symptoms. And they found no correlation between that area narrowing measurement and the development of symptoms. And actually, the majority of the symptomatic patients in their single center group, which is in the 50s, they presented with symptoms by 6 months of age, which is kind of when when some centers are starting to just do routine CT imaging. And so, I was certainly not able to find a specific study that showed a correlation between degree of airway narrowing on CT and symptoms. And again, I think coming back to that initial statement of only symptomatic patients should be referred for surgery. This is actually, again, this study by Gikandi et al., one of the largest surgical series from Dr. Sasaki's own institution. And they found that out of their 515 patients, that almost all of their patients, 92.2%, were symptomatic that went for surgery. So again, I think that, the symptoms should be the key, not necessarily what we're seeing on our non-invasive imaging. And you can certainly make the argument that maybe that will the airway visualization changes the surgical approach. But again, from Dr. Sasaki's institution here, from their aerodigestive team, and talking about their approach, right from the paper, efforts have been made to use dynamic CT to detect airway malacia, but rigid dynamic tracheobronchoscopy remains the gold standard for airway assessment. And their own center utilizes pre- and intraoperative bronchoscopy to evaluate the airway for all of their cases. And I think there are many centers, including Lurie Children's Hospital, that does that. And so it really makes me question, if we're doing bronchoscopy on all these patients anyway, what does the CT airway assessment really affect even the intraoperative management of these patients? And lastly, I'll touch on just quickly about the excellent prenatal detection. Since incorporation of the 3-vessel and trachea view on anatomy scans, fetal detection of vascular rings has increased. These were 3 studies, 2 from Canada. That's Canada, sorry, not California. And 1 from Nevada that showed that, they reported a 10 to 15 year time period and kind of broke it up, but basically showed that over their over time, prenatal detection rate increased. And so these were kind of the most recent timeframes that they reported. And you can see 65, 69, 70% of vascular rings are being prenatally diagnosed. And they made the argument that that allows for timely counseling of patients and parents and closer surveillance for symptoms. So that allows families to know what to look for them to get plugged into cardiology so that we can closely monitor for the development of symptoms and be able to refer patients to surgery. And what do these studies find? Key findings: symptoms were identified sooner. Earlier intervention. What do you know? It actually worked. And so I think that, the funny thing is that third finding was that they found that the combination of fetal and postnatal transthoracic echo is actually highly accurate when compared to the cross-sectional imaging that they got afterwards. So maybe the debate is moot. Maybe we don't even need MR or CT if everyone's getting a great fetal and postnatal transthoracic echo with high accuracy.
All right. I will move on to the pro-CT rebuttal. I don't think Dr. Lee mentioned a lot about the need for sedation in cardiac MRI. So because of the need for sedation, this is a typical indication for sedated cardiac MRI in our institution. And as you can see, there are things like planning for complex 5V repair, double switch, cardiac tumors, stress tests in patients with severe Kawasaki disease. But there, you can see there is no vascular ring. We just don't feel the need to sedate somebody to get information for vascular ring. And this is really why we don't do cardiac MRIs anymore on them. This is a paper from Journal of Pediatric Surgery looking at outcome of patients undergoing general anesthesia in infants. And if you look at the result, I put it in red. It says patients having general anesthesia for MRI had the poorest outcome. So clearly doing general anesthesia in infants for no good reason probably is not the best idea. And I think for those of us who do a lot of sedated studies, whether it's CT or MRI, many of us see atelectasis with intubation, and this can't be a good thing for patients. The other thing he didn't really talk about is the scan duration. Most of the turboflash CTs I do for vascular rings, the actual scan time is actually less than 1 second. It's very fast. Whereas with MRI, it's probably over 1,800 seconds. So here's the answer to which is a better modality. And then I'll just share a typical cardiology management for vascular in here in our institutions. As was said, many patients are diagnosed prenatally. Postnatally, we do transthoracic echo. They get follow-up as outpatient as needed, and then most people do CT scans when the patients are symptomatic, and nobody orders cardiac MRI for these patients anymore. Thank you.
Okay, I thought you were going to say that. So I will say that, yes, I did leave out the fact that the majority of our MRI patients are going to get sedation at that age, but that does not mean we need to. One of our upcoming speakers, Dr. Fogel et al., did publish on the use of feed and swaddle technique to perform an abbreviated vascular ring assessment by MRI. And similar to CT, feed and swaddle, which I believe was invented for MRI, can be utilized successfully. And they were doing this technique, they reported doing this technique in infants less than or equal to 6 months of age. So they had this abbreviated protocol, which consisted of axial single-shot SSFP from thoracic inlet to diaphragm for anatomical assessment, dark blood imaging of the trachea and coronal and sagittal planes, and contrast-enhanced free-breathing conventional MRA. And while their mean acquisition time was 6.2 plus or minus 3.1 minutes, which is, of course, longer than a CT scan, which is really, the snap of a finger, time in room was not significantly different for CMR versus CT, with 31.3 minutes versus 35.8 minutes. And I think, a number of us who have done CT, feed and swaddle, you can already picture, you get the kids strapped up in the scanner, the shusher is going, the lights are off, somebody walks into the control room, you're like, be quiet, So that whole process time in the room was not different than when this similar technique was utilized in MRI. And I will make the point of the airway, just to kind of build on this. As I was looking to see if there were any studies looking at the airway and whether it should impact the the referral of patients, this study tended to come up often. This study by Vigneswaran et al. Talked about 34 prenatally diagnosed cases of right aortic arch, and their main finding was that 69% of these asymptomatic right arch left duct patients, that 70% of these asymptomatic patients had over 70% tracheal compression. And so, of course, the kind of reaction to that is, oh my God, get that CT, look at the airway, like we're missing kids left and right. But when you take a closer look at that study, I think there are a couple problems that came up. First is that the evaluation seems to have been, from what I could tell, 1 or 2 visits. So with some of these kids who, they would see them at the visit and send them for a bronch, with some of them, the asymptomatic ones have gone on to develop symptoms later on. The group that they reported on was in the 30s, but actually the initial group for the whole study is 143 cases, and they discharged 100 of them as asymptomatic, and they did not undergo their bronchoscopy airway evaluations. And that was at the sole discretion of the consultant to refer. So that brings up the question of, there wasn't a standardized way that they were being assessed initially. So, could there be some selection bias there? Thirdly, all the patients apparently received CT and MR, but they didn't comment on any of those findings in the studies. And again, we're not talking about airway evaluation by bronch, we're talking about airway evaluation by CT. So that was kind of a notable omission. And third, 11 out of the 27 operated cases were actually double aortic arches that were misdiagnosed and only correctly diagnosed in the OR. And 7 of the 23 asymptomatic patients actually were double aortic arches. And so the whole study to me raised some questions. I don't really know if it's as clean cut to say that there are all these asymptomatic patients that have significant airway narrowing that they defined on bronch. And then just to kind of build on this again, with more prenatal studies, we know that right aortic arch left subclavian artery is the higher incidence of vascular rings. And a lot of that is coming from prenatal studies. Previously, double aortic arches were reported as the most prevalent. And so, that kind of makes me wonder, have there been more asymptomatic patients than previously appreciated? Are we getting or have there been right arch aberrant left subclavian patients that had a vascular ring, but were asymptomatic and never got picked up? And so if we start CTing all of them and then going off of their airway dimensions, are we going to start operating on more patients as well? So I think that's kind of the question, and what makes me make the argument that we should only be operating on symptomatic patients. And if so, does it really matter MRI or CT, especially if we don't need, we can do MRI without sedation in these patients? Thank you.
Thank you to our fantastic speakers for such a invigorating pro and con for MRI and CT on vascular rings. We're going to shift to our next topic, which is MRI versus CT for pulmonary veins. We have 2 prolific experts in the field debating today. Our first speaker is Dr. Tariq Hussain, who is the director of congenital cardiac cross-sectional imaging and a professor in pediatrics, radiology, and biomedical engineering at UT Southwestern in Dallas. He will be presenting the Pro-CT. He will be followed by Dr. Mark Fogel, who is the professor of pediatrics and radiology, as well as the director of cardiac MRI at the Children's Hospital of Pennsylvania and University of Pennsylvania. He will be debating the pro-MRI stance. And just before I turn it over to Dr. Hussain, I just wanted to remind everyone to please include your questions in the Q&A. We'd be happy to address them. Thank you so much.
Great. I hope you can hear me and see my screen. If not, this will be a very short talk, but we'll carry on. We've been asked to have a little bit of fun, so deepest, sincerest apologies to my opponent beforehand, because I'll try not to have much fun. But I honestly have a disclosure to make. Yes, this is me, Tariq Hussain, MD, PhD. Yeah, the PhD is actually in MR science. So I'll say right from the outset that whenever I can do an MRI, I would do an MRI. It is radiation-free, and our patients need radiation-free follow-up exams. And so Am I biased? Yes, I'm very biased, but I'm biased for my competitor. Now, we've also got to be honest, like, we should all admit, for the last 20 years, anybody who knows anything about cardiac imaging, whenever they're asked anything that's difficult, they will ask themselves, WWMFD, what would Mark Vogel do? And the reason that we ask that, I mean, a lot of times people say, oh, my opponent wrote the book. My opponent literally did write the book. He wrote the book that we all use and we all use to train our fellows. So we always ask that question whenever we want to do anything complicated in imaging. And I think rightly so. My opponent's a great orator and a great history of great imaging. But what would Mark Vogel do? So when I ask myself that question, we see that actually, Mark Vogel could do a free-running 5D whole heart coronary CMRA. And this is with Matthias Stuber. Matthias Stuber, great MR physicist. In fact, he was my PhD examiner. But if you look at this group of patients, we're going to have a few issues. Number one, nobody has access to this, apart from perhaps Children's Hospital Philadelphia and Matthias Stuber in Lausanne. No one has access, and nobody likely will have access for the next 5 to 10 years. The other thing is, Ferumoxytol, yes, I use a lot of it, but it's just not available when I go around the world. It's not available outside of America. And even if it is available to me, sometimes the insurance companies give me kickback. So it's not the answer. And even more than that, we have to say that even in this group of patients that are getting free running 5D, the best of the best, the majority, anyone below 1 year of age was having anesthesia. And I take Simon's point about his paper that he talked about deep sedation. In another way, another word for deep sedation is in fact anesthesia. Moving on, what would Mark Vogel do? So let's have a look at what Mark Vogel would do. In fact, if we have a look at his institution, if you look at Dr. Callahan there, who is the medical director of CHOP's pulmonary vein stenosis program, he says MRI is less commonly employed as a screening or surveillance tool in the management of pulmonary vein stenosis. It is limited by the duration of the exam, the need for sedation, artifact from previous stent implantation, as well as a limited spatial resolution it provides. I think unfortunately, he says it all, but I will tell you again, once again, I am biased in favor of MRI. If I can do an MRI, I will. So why don't we look at what I've done over the last month? So if I look at October, in October, I had 10 specific requests for pulmonary vein imaging. One of those, and bear in mind, this is an 8-year-old. I will try and do an MRI whenever I can. I did do an MRI. This 6-year-old, I strongly advised for an MRI, but the referrer refused because there was a long travel time and then she didn't want to be unsuccessful and she was a little bit unsure about this particular child's cooperation. The rest of the patients got CT. Why did they get CT? Well, they were infants, so we needed to have a rapid exam. But not only that, you want to avoid any type of sedation in patients with severe pulmonary vein disease and pulmonary hypertension because they are high-risk patients. The others couldn't get near to having an MRI. They had pulmonary vein stents, they had ventricular assist device, and one of them had an AICD coil. And I'll show you, I will be the first to do an MRI with an AICD coil, but I couldn't do it in this case, and I'll show you why in a second. So yes, you do need exquisite resolution, because when we're thinking about what to do for this very stenosed pulmonary vein, we need to tell not only where the obstruction is, how long is the obstruction, when does it get better, is this a diffuse stenosis, is this a discrete stenosis that's amenable to intervention. I'll try and help you out a little bit here by not only talking about what is pros and cons, because at the end of the day, as I told you, I am in favor of MRI. I'll be the first to vote for MRI. But what I want to do is to give you a framework which is workable for you to take home and use in your institutions. Yes, you can do 3D, but you can also have a look at strut fractures and important stent displacements. Not only that, this is a patient that got CPR. And you can see this was actually before CPR. This is a volume rendering of the CT, and this is after CPR. You'll miss this on nearly every other modality that we had for this patient. The stent was compressed during CPR. This happens, and you'll miss this unless you actually image the stent itself. This is our VAD. In a VAD, I strongly advise you to avoid MRI, no matter what Mark Vogel will tell you. This is an AICD coil. This is where it was placed in the oblique sinus. There is no way that I would get MRI imaging with the AICD coil in the oblique sinus, but as you can see here, the patient had a blocked right upper pulmonary vein and collateralization to the right lower pulmonary vein. I won't even talk about this very much. Yes, we can do lung parenchymal imaging. Yes, it's felt to be important when looking at these patients because obviously it gives us some kind of idea about prognosis. This is, again, from Dr. Callahan's own work. Work from Boston also shows that the lung severity of disease also correlates very highly with the level of pulmonary vein stenosis. So again, giving some additional information in these patients. This is our protocol so that you can hopefully take away what we do. We use a dual source fast pitch spiral acquisition. It's non-gated. You don't need gating for this. So we do often do a delayed second acquisition, can be helpful to rule out chronic total occlusion. We do measure the area of the stenosis. That it has been helpful in our series, a small series of 23 patients. Those patients with an area of less than 50 millimeters per meter squared, and this was published by Mauro Lurito from work done in Toronto. By the way, that was the work that 50% of the patients had MRI, 50% had CT. And that's the work that's quoted by Dr. Callahan to say that some centers use MRI. But this cutoff of 50, we found to be quite indicative to whether the patient needs intervention or not. Finally, yes, have a look at this paper. It gives you some kind of insight of what diffuse stenosis is and what focal stenosis is. And then finally, I'll leave it there. And a huge thank you to the team who've been fantastic in looking after these patients and developing protocols, and especially Lauren Tai and Mahir Abadir, whose work I showed here. Thank you.
Okay, so first, I hope everybody can see my screen and I'm sharing. I first want to thank the organizers for giving me the opportunity today to convince you that cardiac MRI is the way to go for pulmonary vein imaging, and that all of what Tarek just said was hogwash. So here's my disclosure slide, and in the interest of full disclosure, since it is football season, I have to say that I am an Eagles fan, and I hope that's not going to color green everything I'm about to tell you in the next 9.5 minutes or so. So here's Gil Warnowski, who taught me everything I know about debating. His approach to debating: one is to have fun, and then you have to put 4 key components. One is give you a concession immediately right off the bat. 2 is to find dirt on your opponent. 3 is to have your opponent support your point of view, and 4 is to make your point. So let's start off with a concession. So the role of CTA in pulmonary vein imaging is, there is one. One is contraindication or artifact in CMR. One is a contraindication to anesthesia for those who need it. One is if you have a critically ill patient or those who can't spend 10 to 14 minutes in the scanner, and when 0.2 millimeters of resolution would make a difference. And that's the difference in between what we can get with femoxetol, which is 0.8 millimeters isotropic resolution, and what the native cardiac CT resolution is that's not interpolated at 0.6 millimeters. And for nearly all applications, the added resolution wouldn't make a hill of beans difference. And finally, for any physicians whose family members are actually oncologists, and we can talk about that in the rebuttal. Now, another concession is that CTA is faster imaging. CMR takes more time because it's asked to do more. Now, we have to compare apples to apples. CMR solely for anatomy, using just this protocol alone, which you can get just the anatomy without contrast, I have to say, is 10 minutes. If you use contrast, it would take, with a diaphragmatic navigator, it'll take 14 minutes, not the onerous hour that was just posited a little while ago in our vascular ring talk. Finding dirt on opposition. Okay, Tariq is a saint on the internet. I could not find anything. I was expecting to find party Tariq. I was expecting to find muscle-bound Tariq, but I kept finding MRI Tariq as he suggested. Well, here's two examples of Tariq talking about pulmonary vein imaging by cardiac MRI, and you can see his name is on the masthead here. One of them being him being the senior author, and you can see he talks about small right pulmonary vein in the upper panel illustration. On a lower panel illustration, he's talking about left upper pulmonary veins, left lower pulmonary veins. From a resolution standpoint, I can't imagine a professor would say something like that if he couldn't actually see it. The man is even using cardiac MRI for interventions for pulmonary veins, not CT. And here, once again, is Tariq being the senior author and coming from the paper itself, entering the LA for pulmonary venous saturation. So he's way in there. Now, you don't have to believe me or believe Tariq. Just follow the guidelines. So here is something that was published in Circ Cardiovascular Imaging in 2022 that was backed by SCMR, ESCIA, CVI, ASE, NASCI, et cetera, et cetera. And when you look at this blurb for pulmonary veins, you can see MRI is indicated for anatomy, hemodynamics, for surgical planning, for complicated CHD, for follow-up, and all those are class 1 level of evidence B, with the exception of the follow-up, which was class 2A level of evidence B, because that's followed up a good portion of with echo. What about national organizations like the 2018 AHA-ACC guidelines? So let's look at the recommendations for imaging and generally that you have to do studies with ACHD that try to avoid ionizing radiation when appropriate. If you look at the recommendations for actual pulmonary veins, and which also includes atrial septal defects, serial MRI is recommended for evaluation of function, and serial MRIs can be useful in selected CHD patients with follow-up for anatomy and clinical status. And then finally, in this recommendation, CCT should be used when other imaging modalities cannot, only after other imaging modalities, and is important enough to justify the exposure to radiation. So why is Tariq and I so excited about cardiac MRI for pulmonary vein imaging? Well, CT is a first-pass study where you can get, yes, exquisite anatomy, as well as function, but a little bit less accurate and not considered the gold standard like cardiac MR. But cardiac MR can also get exquisite anatomy, both in multiple different techniques, which is non-contrast static and non-contrast dynamic, including bright blood and dark blood, and both combined. And of course, we can do contrast-enhanced imaging with gadolinium and femoxetol, both dynamic imaging as a first pass, dynamic with femoxetol using the music sequence, as well as static imaging like an IR flash or a boost. And of course, we use ventricular function and flow with a QPQS in planar velocity mappings and 4D flow. Now, now CT needs IV contrast to visualize the pulmonary veins, and Tarek will be the first one to tell you that if the CTA contrast misses the pulmonary veins, bolus timing, technical problem, the patient has to come back and you're up the creek. Whereas with CMR, you can use non-contrast imaging or you can use femoxetol, and CMR can just try again, modifying the sequence itself. Now, anatomy without contrast, remember CTA needs contrast to visualize the pulmonary veins. So that's really 20th century and very quaint as you can see. Here is an example of a 3-year-old rule out partial anomalous pulmonary venous return using boost with bright blood on the left and dark blood on the right. You can see the dark blood, the coronal set going back and forth where you can easily see the pulmonary veins. But here, of course, we do use contrast as well. And here you can see the exquisite detail in this 3-month-old with the right upper and right lower pulmonary veins. And you can see the 3D, and as I stop it posteriorly, you can easily see the pulmonary veins. And as a matter of fact, you could probably mistake this for a CT had I not told you that it was a cardiac MRI. Now, Tarek, being a pediatric cardiologist, he knows there's more to evaluating pulmonary veins than just anatomy. I mean, there's ventricular function, RV dilatation in patients with partial anomalous or total anomalous pulmonary venous return using the RV ejection fraction. There's flow, looking at the branch pulmonary arteries, because the ipsilateral pulmonary artery from the pulmonary vein stenosis should have lower flow, which might be an indication for surgery. Looking at pulmonary and aortic velocity maps, plus their checks for QPQS, again, in partial and total anomalous pulmonary venous connection. And then there's using in-plane velocity maps for velocities in pulmonary vein stenosis, like you can see down here, both black and white, as well as in color. And of course, through plane velocity maps through the pulmonary veins to calculate systemic to pulmonary collateral flow in single ventricles, which we published way back when, about 15 years ago, with the group up in Toronto. And then, of course, there's both combined physiology as well as anatomy. When we use dynamic gadolinium injection, you can see that injection on the right, and on the left, you can see the 3D, and this is clearly a patient with an anomalous left upper pulmonary vein to the innominate vein. And then, of course, there's everybody's rave, which is 4D flow, which you can get physiology plus anatomy. And we're looking at this posteriorly, where you can see all the flow vectors in the pulmonary veins in the back of the left atrium. And finally, we have to end up with a case. And this is a case with a follow-up partial anomalous pulmonary venous connection to the SVC after a Warden that had gone terribly wrong, which I'll tell you about in a second. And for those of you who don't know what a Warden is, if you have anomalous pulmonary veins to the SVC, we baffle the SVC. We baffle the pulmonary veins through a baffle into an ASD that's created into the left atrium, and then widen the SVC so that flow can go across. Now, here's the 3D of that patient, and you can see as you're going around, this could be just a typical CT, and you can see that there is, if we zoom up on it, there's some sort of funky pulmonary vein. There's some funky systemic vein that's going posteriorly from the innominate vein, and it's squiggly, and it goes down below the diaphragm. And if you were doing a CT, you'd say, oh, something's a little up. Maybe the SVC is a little bit small. However, you wouldn't do a dynamic imaging with CT, but here you can, with gadolinium and a dynamic imaging, you can see there was an injection in the left-hand side, and there was blood that went both retrograde in the right azygos and in the left hemiazygos going below the diaphragm, that then went up to the SVC, as well as showing with velocity mapping that there was literally only 0.2 liters per minute of flow going through the SVC. You would know none of that if you were just doing the CT, which you would see on the right. And you'd be missing things and doing your patients a disservice. So I want to summarize by saying there is limited but a definite role for CT imaging in pulmonary veins and congenital heart disease. Cardiac MRI has multiple ways to visualize anatomy, not just the one with CT, without contrast, as well as with, and how quaint, as opposed to with contrast. We can do ventricular function as well as flow, both with 2D as well as 4D. And listen, don't believe me or Tariq. Follow the guidelines. And I always like when I talk about CMR versus CT, I always like to quote Woody Allen's Deconstructing Harry, which said, all people know the same truths. Our lives consist with how we choose to distort it. And I'm done, and I know that Tariq's distortion is done. And I want to thank you for the privilege of your attention and give credit to a lot of the people at CHOP who enabled cardiac MRI at our institution. Thank you.
Okay, hopefully you can see my screen in a second. And you can hear me, I hope. So, you know, hats off. That was a wonderful argument, and I really applaud Mark also for making more fun of and some beautiful images of making fun of me. So I don't feel as bad about what's about to come. My point of view. So yes, I 100% agree. These are the problems with CT, radiation exposure, and we don't have physiology. But these are real issues, and I applaud Mark for also giving me the argument that MRI is not good for critically ill patients. And the real problem is that the indications have changed. So when Mark wrote his books, we were all doing this. We were also doing post-surgical baffle repairs, Fontans, anomalous, showing the anatomy, very much as Mark showed. But the problem is now, is the interventions have changed. They're more available. Everybody's got stents in. And very much like coronary imaging, there are no interventionalists going around asking for coronary MRA in order to make their interventional planning. So that is a problem. And that is the thing. So I will just give you some advice. Okay, do not anesthetize the highest risk patients in the hospital. That is the patients with pulmonary hypertension. And these patients with pulmonary vein disease are those patients. Don't think that you're going to easily feed and swaddle because you read a few papers on 5D ferumoxytol and that you think that this is going to come to a center near you anytime soon. Unfortunately, it's not. I do wish for that, but that's not going to be that. Resolution is important. Mark mentioned resolution is important, and we're not talking down to 0.2 millimeters. There's a reason why coronary MRA hasn't taken over compared to coronary CTs, because we're trying to plan interventions. And you won't be imaging LVADs or stents or looking at the stent integrity or devices with any diagnostic clarity, but do a rapid CT protocol. If you want to look for chronic total occlusion, consider a late phase. Do use the area criteria. We found it very useful. Do write in your reports whether this is diffuse disease or proximal disease. Image the stents, image them well, and image the lung parenchyma also. And what would Mark Fogel do? Well, this is what his director of CHOP's pulmonary vein program says. CT is valuable for procedural planning and surveillance monitoring. Not only that, he says, unlike even angiography, CTA can characterize a relationship of importance surrounding vascular and soft tissue structures, blah, blah, blah. Basically saying that he prefers it to his own angiography. And then he says something about severity scoring with lung disease, etc. What does, don't take my advice for it, what does Google AI say? Well, Google AI says, in fact, CT is the preferred imaging modality. Now, I take offense to that, but we should finish it on a light note and say, look, I believe in the fairy tale of MRI, but there is a brutal honesty here that I just showed you our data just for the last month, 9 versus 1. And that was 9 cases that were suitable for CT versus 1 case. And that's with me trying to push MRI. as much as possible. And yes, this does look like the 2014 Brazil versus Germany scoreline, but it's worse. 9 versus 1. Thank you.
Okay, well, I hope you can see my screen. First of all, I do want to thank Tarek for his lighthearted characterization. I do want to mention, and please note that he's quoting this thing from 2002 from my colleague Callahan, and of course, I have to talk to Callahan about how much Tarek paid him under the table to say all this. But it was really from 2000. So if it was published in 2002, it's really from 2022. It's really from 2021. And I have to say that ever since we've had a protocol with femoxetol, it's really changed his mind and his thinking. And unfortunately, I wish I had anticipated the stent comment. I don't have any of the femoxetol IR flashes or boost, but I do. But you can actually have decent visualization of the lumen with femoxetol and IR based and IR flash or boost sequences and femoxetol. And I noticed that Tarek didn't say anything about you still do get artifact in the lumen with CT. I do want to I wanted to also rebut his rebuttal that says if you're a physician or you're a patient or a patient's family and you say, do I want to go with the recommendation of Google AI or should I go with the guidelines paper that's been approved by multiple experts? I think if I was a patient or a physician, I'd want to go with the guidelines. I do want to address one or two real quick things before we close about anesthesia and development. Less than 6 months. I don't know where Tarek trained, but here at less than 6 months, for 15 years, we've been doing the feed and swaddle. We published one in 2011, and now we've even been doing that for 45 minutes in patients with tetralogy of Fallot, and that was published in 2018. So it's under 6 months that you can do this without sedation. So we're really talking about less than 3 years and greater than 3 hours of anesthesia, which is what the issue is in terms of neurodevelopment. And we would never need greater than 3 hours to image patients. And there's multiple issues with the present studies on the correlation of anesthesia and neurodevelopment. Though it has to do with multiple issues with confounding factors of underlying disease. Nearly all the studies are retrospective, and there's no details of the anesthetic. So yes, if you took a cursory glance at the paper, yes, you would automatically say that this is an issue. But then those of us who really try to look at this scientifically and try to figure out what is in the best interest of the patient, we would want to look at all these other issues like the underlying disease, and nearly all retrospective and no details of the anesthetic. I do want to talk about a little bit of radiation. There's a lot of, and that's a whole hour talk in and of itself. However, the dirty little secret that nobody ever tells you is that the presence of contrast agent increases organ radiation dose in contrast enhanced CT. This came out in 2021. All the phantoms that everybody relies on in terms of their radiation dose don't have contrast in it. And you can see here, if you look at these graphs of the aorta on the left and the spleen dose on the right, the absence of contrast is down here on the dosing over on the left of the graph, but on the right of the graph, you can see the dose in the presence of contrast raises things fairly significantly, both in the aorta, in the spleen, in the kidney, and in the liver, and basically it increases it by at least 30% in this takeaway message. And then it's the same thing over here in this publication that happened in 2023, and I'll won't go through it in great detail because of time considerations, but it increased it 55% higher in contrast CT doses than without contrast CT. And finally, the last thing I want to talk about, and my last slide, is that everybody keeps saying, oh, it's a little bit of radiation. Oh, it's only photon counting CT, so he's only going to get a little bit of radiation. It's only a little bit of radiation when it's the other guy. Okay, how many times have you sat in a dental chair and you looked up at the dental radiologist who's about to take the X-ray, who says, "What the hey? I don't need any lead apron. It's just a little radiation." And literally, if you look up what an X-ray dose is for a dental X-ray, it's literally 2 microsieverts. Forget about millisieverts. We're talking an order of magnitude difference, and yet nobody would ever say, "No, I don't need a lead apron. It's only a little bit of radiation." And I think I'll stop there. And thank you for your attention.
Thank you so much, Dr. Hussain and Dr. Fogel, for some amazing talks and for keeping it very lighthearted. We appreciate all of that. We have some good questions that have come in from the participants. Dr. Javeri, would you like to start off with one from Vascular Rings?
Yeah, sure. So maybe we can answer the question that Dr. Steele asked to Dr. Lee. So what is sort of your institutional protocol for vascular ring assessment and MRI? Do you tend to use anesthesia? And also, in the lack of MRI, are you routinely doing CTs on these patients postnatally?
So I will say, in full disclosure, of course, this is a debate format, but it was very hard to find MRIs of vascular rings at Lurie because we always do CTs. So we are not doing the feed and swaddle MRI, like short MRI protocol for our vascular rings. The majority of our patients do get feed and swaddle CT scans.
Great. And do you tend to do them electively in the neonatal period, or is that something that only happens if they're symptomatic, as you were talking about?
Yeah, so there's been a little bit of variation, practice variation among our group, although we just recently kind of got together and tried to standardize what we're recommending our entire group does. So we are, again, full disclosure, doing around 3 to 4 months, whether they're symptomatic or not, a CT scan, feed and swaddle. But we don't typically repeat it unless there's some change that occurs or there's a concern that the surgeon brings up.
So we do feed and swaddle for patients generally less than 6 months. We're nearly always successful. And it does take a little bit more time because you have to wrap the baby and stuff like that. But literally within the first set of axials, you can tell whether or not it's a vascular ring and what kind of vascular ring it is. So even though that paper said it was six minutes, if you read the paper, it also said that the initial diagnosis was in the first 30 seconds, because that's when you can get the stack of bright blood images and see, one, if the trachea is compressed, and 2, what kind of vascular ring it is. So I appreciate, and we generally just do patients who are symptomatic.
Dr. Lee, for someone that does CTs at their institute, I must applaud you on your pro-MRI stance. You made a case very strongly. And I guess we have a few more questions that are coming up in the chat box.
I actually wanted to just ask from the pulmonary vein standpoint, for patients who've had pulmonary vein stenosis intervention with stents, for example, institutionally, outside of the world of this debate, I imagine, Dr. Fogel, you might use MRI more, but I was just curious, is there a threshold at which your institutions prefer CT? And do you have some sort of protocol post-intervention where you might screen them periodically with some sort of advanced imaging to kind of be an adjunct to echocardiograms? Because I feel like looking distally after they've had pulmonary vein stenosis can be very challenging on echo alone.
So, so really, the pulmonary veins is just a conduit. If it's small or it's large, it doesn't matter. What matters is the physiology and the hemodynamics, and that's cardiac MRI. If there is if there's a 20% flow to the LPA and there's left pulmonary vein stenosis, that's different than if there's 40 or 50% flow to the LPA and there is a narrowed left pulmonary vein, right? So the physiology, one, is very important. And two, we usually use femoxetol with an IR flash or a boost sequence that will give us a pretty good idea of the diameter of the pulmonary vein with the stent. Having said that, in babies, where it's really small and you really do need a high resolution, we would still try to opt for. We would also try to opt for the CT and probably get both. Probably get an MRI for the physiology and the function and the hemodynamics, and then if the cath guys needed to know what the dimension was before they did angiography, they would get a CT.
I mean, I'll just agree with what Mark says, because that's what I generally do anyway. But I think that we are trying to do more pulmonary vein stent imaging. We do obviously use femoxetol with MRI, and we do use the flash IR, and we're even going to hopefully publish soon our experience with ultra short echo times, trying to have a look at stents. So we'll probably have a little bit more information about how we can really look at stents and what type of stents we can look at reliably. But as Mark said, anybody who's put a stent in will want to, at this stage, have an MRI, have a CT, and look at the integrity of the stent. As I said, there are patients that have collapse of the stent, and they're not going to be picked up very easily on any imaging modality apart from CT, and also looking at intimal proliferation and issues within the stent. I think all interventionalists are going to want to do that.
Although Tarek, you have to admit too that if the interventionalist is going to be there, they're going to do an angio, and they're going to be able to see the.
Yeah, but they don't want to do repeated angios. So as part of their follow-up, I'm sure they're going to request a CT at one point, is what I'm trying to say.
Sure.
Yeah.
And did you want to ask one of the vascular ring questions? We can see what else there was.
So I guess there's a question about available MRI sequences for airway assessment, and if there's any design for real-time airway dynamic assessment.
I mean, we generally use dark blood imaging for like a double inversion IR for imaging the airway, or a 3D space, which will give us about it's a 1 millimeter resolution. We don't do dynamic imaging because, as Simon pointed out, lots of times we would just do it as if a patient was symptomatic, and we never ever do any airway imaging with a patient who is intubated or with positive pressure ventilation, because that would artificially expand the airway, and then you're going to overestimate how big the airway truly is if you have positive pressure ventilation.
I think the question's also a good one, right? It's what's the feasibility of dynamic airway imaging, and what is that feasibility with MRI, and does anybody actually do it in CT? It is feasible on MRI. You can use cine imaging and have a look, exercise of patients, older patients. That is possible. it's possible also with CT. It is high radiation. There are centers that are using it, but again, I'm wondering what the exact indication is for doing that. If you really want that information, shouldn't you be doing a bronchoscopy, a free breathing bronchoscopy? That's the gold standard. Should we really be doing high dose imaging, CT imaging, to do dynamic airway assessment? I'm just not sure. And people that do dynamic airway assessment, how are you doing it? As Mark said, are you doing it with positive pressure? Are you varying the peak? That's not quite the same as negative pressure ventilation. So those are already questions that I think that we need to answer as a community.
Thank you, everyone, for the insightful answers and for the questions. I think we should close out our Q&A at this time. Again, thanks to all of the participants for joining and for all the speakers. This was a wonderful debate, and we all learned a lot. Thank you so much.